So I really like to bring awareness to women's heart health. I've been a nurse for 32 years, and most of my time I've spent in ICU at St. Boniface, as well as the angio lab and EP labs and coronary care unit at St. Boniface. So I've seen a lot of men and women go through there, and the differences are fairly significant over the years that I've seen in the treatment of men and women differently. And we're getting better, but there is still some myths around. Actually, the American Heart Association in 2019 did a study of awareness of women's health issues. And this, of course, was in the US because it was a very large study. But there was still this misperception that cardiovascular disease is a man's disease and women should be more concerned about cancer for premature death, where the leading cause of death in America is cardiovascular disease. The leading cause of death in Canada is still cancer, but not by much. Okay, not by much. Heart disease is for old people. Well, there's a continuum of heart disease now. And the earlier we start recognizing that some things that we do contribute to heart disease later on in life, the better we are at prolonging life and making your quality of life better later on in your later years. Men and women's hearts are not the same. Obviously, you have somebody who's 6'4", who's 250 pounds, and someone who's 100 pounds. There's a big difference in the size of the heart. And heart disease in men and women is the same. It's not. Men have very different syndromes. Women have other syndromes. We have very different anatomy. We go through different stresses in our life. Think about pregnancy and menopause and all of that, those major changes. So all of those things contribute to ways that we have opportunity to talk with our doctor and know our health history and prevent things that can lead to cardiovascular disease. So hopefully by the end of this, I gave you guys a little handout there. Hopefully by the end of all of this, you understand what your risks are. You can understand what ones you can change and what ones you can't. Know when to seek help and how to tell a good story so that you get the help that you need. Know your numbers, which is that sheet, and then know the connections in the community. This is one, but I have a whole bunch of information about ways to seek information in the community within Manitoba and beyond to get more information and help and online resources, all that kind of stuff. So we've come a long way, baby. There's, I think some of you remember Sanford and Son when we had, what was his name? I'm having the big one, Alice, right? That was the, that was the big drama, was that he's having a heart attack. And that was amazing for awareness of men's heart issues because central chest pain, radiating down the arm. It was on prime time. It was a comedy show. People understood that was sort of how a man would present. We didn't turn the corner for heart disease intervention with heart attacks until sort of the mid-1990s when we developed stents and then we advanced stents. There was a lot of information done on men because men presented very dramatically with that, I'm having this huge pain in my chest. Women present very differently and later. So there wasn't a lot of studies on them because it was hard to find a definite beginning point to women's heart issues. Heart and Stroke in 2020, just before COVID, put out a call to action for more women's health research. And since then, actually, there's been a whole bunch of really good research done, which is amazing, both in the US and in Canada. And just recently in 2023, there was AHA really big article on women's heart health. So we're doing good. We still need to do more, but we're doing really good, which is impressive in a couple of years. So these are traditional risk factors for heart disease, and those are listed on your sheet. These are things we say you can change. These are modifiable risk factors. The first one is cholesterol. So you can see on your sheet, you've got your cholesterol profile sort of written in here. I invite you guys to take this to your doctor, or if you get a phone call with your doctor, say, hey, what was my last cholesterol? And know your number, right? A lot of times our physicians will say, oh no, your cholesterol's good. Or, we'll see how it is in 3 months. We'll do it again in 3 months. Same with your blood pressure. If you know your number and you know what your target is, then you can work towards that target. And I'll get into sort of behavior change and modifying your risks in a little bit. But it starts by knowing. Sometimes your cholesterol targets, these are very general cholesterol targets. If you have other risks, such as cardiovascular disease in your family at a young age, your targets might be tighter or lower. Okay, if you have diabetes, your targets might be lower. So it's important to know what your numbers are and if you are on target or if you're approaching target. So managing that is important as well. Blood sugar is also on here. So just when you talk to your doctor about your cholesterol, you can get your blood sugar result as well. There's also another number associated with blood sugar called A1C. Have you guys heard of that? It's a fancy term that's called glycosated hemoglobin. What it does is it takes a look at the amount of sugar attached to red blood cells. And red blood cells, they last between 30 and 45 days. So if there's a lot of stickiness, if there's a lot of sugar attached to those red blood cells, it tells us that your blood sugar was generally high the last month or so. It's a little bit of a better view than just taking a blood sugar result that is a point in time. Blood sugar result as a point in time is a good measure as well, but it's part of a puzzle. And if we don't have all that information, it's good information to have both. So we do that blood test, the blood sugar as well as the A1C, to see if you're pre-diabetic. Have you guys heard that term before? So pre-diabetes just means that you are at risk for developing diabetes. And once again, your doctor goes, oh, you're at risk of developing diabetes. See you in 3 months to do something about it, right? So it's important and it's hard to know what to do about it if you have a 5-minute visit or a 10-minute visit with your doctor. The other modifiable risk factor is smoking at the very bottom there. And that includes smoking, just regular smoking, and smoking cannabis as well. There's a lot of chemicals in that. They affect women disproportionately more because we have smaller blood vessels than men. So some of those chemicals can cause artery spasm. They can cause changes in the lining of our arteries disproportionately more than men. So smoking in women is really important to reduce that effect or that risk on our heart health. Now, hypertension. I can remember being a little girl and having my grandma, who was probably in her 60s, early 60s at the time, taking her blood pressure pill. I think there's a lot of women that have blood pressure issues or have treated blood pressure over the years. And that's one thing that I think we've done a decent job of making people or women aware of. Blood pressure is an important thing to modify in order to reduce the risk of cardiovascular disease. So blood pressure consists of 2 elements. The top number is called your systolic number. That's the force of your heart ejecting blood. So if your heart is sitting here in your chest and your heart squeezes like it does 60 to 100 times every minute, that pressure goes over your aorta and then into your arm. It actually splits off and there's a whole bunch, right? Go up into your neck, right? So we take your blood pressure here or here, and that tells us a little bit about the force that your heart is able to generate, pushing blood forward. That's that top number, the systolic number. And it's expressed in millimeters of mercury, but you just have to know that sort of we're looking for a number sort of less than 100 and like 140 over 90. That's a sort of a high sort of number there. If you're diabetic, we do try to get that a little bit lower, and I'll explain why in a second. But when we take our blood pressure, we want to be resting. We want our arm to be supported. We want to take a few nice big breaths. We want to have a resting number. When we take that resting number, that's the best that we can be, right? We all know that, driving in this weather, getting to an appointment, being stressed is going to elevate your blood pressure. And it's okay to take your blood pressure then, but you have to realize that that's not your resting blood pressure. When medical professionals treat blood pressure, we want to treat the resting blood pressure, because if it's high at rest, then we need to lower that. Because there are things during stress, during exercise, etc., that we can do as women to relax and to reduce our blood pressure. But if it is high at rest, that's when it's really important to really manage blood pressure. So if your doctor tells you that you need to reduce your blood pressure, or your blood pressure is borderline high, there are a bunch of things to do about your blood pressure, that will help reduce blood pressure and reduce your cardiovascular risk as well. So this will all come together sort of at the end, that some of the things that we do affect many different parts of these risks, and it's an additive effect as well. So the next thing I'll talk about is obesity. So women are more likely to have obesity, especially later in life, than men, believe it or not. With change in menopause, premenopause, sometimes, well, most of the time, women spend about a third of their life in menopause. And so that is when the technical definition is when ceasing of monthly cycles for a year. A lot of doctors will do some tests on stimulating hormones, etc., to see if you are actually in menopause. And there's been a lot of talk on social media about doing estrogen replacement or hormone replacement therapy to sort of ameliorate some of the symptoms of menopause. And those have become safer in 2024. There are very low dose hormone replacement therapy that can be done to alleviate the symptoms of menopause. We're still, American Heart and the Canadian Medical Association are still sort of resistant to treating cardiovascular disease with hormone replacement therapy as a primary endpoint. So there is a discussion with your doctor if that's something that is important to you. But we know that when estrogen decreases as women age, or on the onset of menopause, we end up gathering a little bit more in the middle here. It usually corresponds with a time of life where you may be less busy, or you may be more stressed because of changes, kids leaving, marriages, grandchildren, all of that kind of stuff. And that can also contribute to adding a bit of extra weight here. This extra weight, unfortunately, can lead to prediabetes. So it can lead to having a bit of insulin resistance, which of course increases your cardiovascular risk. Carrying a bit of extra weight also, unfortunately, can lead to high blood pressure as well. So the key to all of these risk factors is that you guys are in control, okay? A lot of these are very modifiable, and one of the main things that modifies these, all of these, is exercise. Believe it or not. I know, I'm at the wellness, right? So I'm the choir, preaching in the church. But it's incredible what even 20 minutes a day can do to all of these numbers. It's stunning, actually. So some non-traditional things that are risk factors for women, and I'm putting these out there just because I know the healthcare system right now is in turmoil. It's hard to get a family doctor. If you have a family doctor, you probably have a family doctor that's like 26 years old, right? So knowing yourself and being able to convey that to your family doctor if they don't know you and they only have 7 minutes in front of you is really important. So if you have diabetes in your family, especially type 1 or type 2 diabetes that develops later on in life, that's important to convey to your doctor. If you have cardiovascular disease in a genetically related relative that started before 55 in men, 45 in women, that's important to convey to your doctor, because then these targets that are on your risk factor sheet might shrink a little bit, might get a little tighter. High blood pressure, of course. There is a small genetic factor in hypertension, and there's a small genetic factor in obesity as well. So the other things that your doctor may not know about you if they don't know you for your whole lifetime is your reproductive history or your female history. So things like breast cancer treatment. Some of the medications that we use to treat breast cancer can have cardiovascular effects. They can be treated and kept, an eye on and managed, but it's important for your doctor to recognize that. Treatment for depression or having depression can cause big changes in just in our body chemistry, from anxiety to depression, and then treatment of those things. They can cause, having depression or anxiety can cause changes in blood pressure, which is also hard on our cardiovascular system. And of course, our reproductive sort of events that happen. Having a child being pregnant is a 9-month-long stress test for your heart. Your blood volume doubles, your heart's contractility, or the amount of squeeze that your heart has to do to feed that baby and to keep you going, is incredible, actually. And then all of the changes that go on with the hormone fluctuations with nurturing this child inside of you. Some things that can sort of not go according to plan during pregnancy are hypertension. So if you have pregnancy with hypertension and you're treated for that, that can actually contribute to a 60% more increase of having hypertension later on in life. Okay, same with gestational diabetes. If you have diabetes during a pregnancy, it sort of is a marker to say you probably will develop diabetes later on in life. Preterm delivery, that can also be just a hallmark of that your other risk factors need to be controlled very well in order to manage your cardiovascular risk. Any questions about that? No? So non-traditional risk factors for women's heart health just continued. Women are disproportionately presented with rheumatoid arthritis, lupus, and scleroderma. All of 3 of those can affect your cardiovascular system. Scleroderma causes hypertension. Lupus causes an inflammation sort of systemically. And so does rheumatoid arthritis. So it can cause an inflammatory response within your cardiovascular system as well. So managing your risk factors, right, is going to help reduce that inflammation. Things like chronic kidney disease and polycystic ovarian syndrome can predispose women to having high blood pressure and having potential heart rhythm issues. So once again, this is all so that you have a list of who you are, so that when you talk to your doctor about what you need to do or what you need to control, that your doctor has a very good idea and how to manage you or to help you manage your cardiovascular risk. So women are not small men. We figured that out a long time ago. I've got a little model of a heart here. It's not a little model, it's a huge model actually. this is not my heart. Your heart's about the size of your fist. So it sits, oops, I lost a ventricle. Oh, I lost 2 ventricles. Okay, put those there. So your heart actually sits sort of off to the side, off to the left side a little bit. And the heart arteries that feed this muscle, that do all the work of pumping, there's only 3 arteries that do all of that. Okay, your quad muscle has more than that. So it's an engineering marvel, but it's also, there's some sketchiness there. So when we think about how the muscle of the heart is oxygenated or given nutrients, you have these 3 heart arteries, and they're very easily seen. We can even see on this picture, you can see there's sort of a groove there. They're on the outside of the heart, so they don't get squeezed when your heart contracts, but they're like the trunk of a tree. So blood flows through here, and then it infiltrates into the muscle of your heart, and gets into smaller and smaller and smaller vessels. Now, when you start off with a giant oak tree, like in a man, the branches get smaller and smaller, but you can see more of that, right? You can see more of those larger branches. But if you're starting off with a smaller tree, say you've got a little sapling there, because women's vessels are smaller, because our hearts are smaller, it's going to be harder to see those smaller vessels as they branch off. Does that make sense? Okay. So women, when we send women for diagnostic tests and we look at their macro circulation, so the things we can see, sometimes it says it's normal, but it's the micro stuff that we can't see because our vessels do get smaller quicker. They branch off quicker, that it makes it difficult to diagnose some things with women's heart syndromes. So traditionally, what happens in what we call something called ischemic heart disease. So ischemia just means not enough blood flow to the muscle. Traditionally, what happens, or what we thought what happens, is that cholesterol builds up on the inside of the arteries, and it builds up and becomes hard. And then for some reason, it breaks open and it causes an occlusion or a full plug in the heart artery. That's sort of traditionally what we started treating way back in the day with stents and with all the fancy stuff that we were doing. That's because we could see the heart arteries of men generally, and that's what we treated. Now, with women that have smaller vessels, their vessels get narrow, and they're so small that we can't see them. And even so, when I was working in the cath lab, late 90s, early 2000s, we had a wall full of stents because it was the new thing, right? We were going to open everybody's heart artery, no problem. But it was one size. We had different lengths, but it was the same diameter. Men, women, whatever. It was the same size. So we would put this stent in someone's artery, and it would be too big for them. It's sort of like putting on a big pair of shoes, right? Then we started developing different sizes, more different lengths. They started putting drug coatings on stents so that they would heal into the body faster or better. But it took an evolution of about 15 years to do that. And I still remember we had a 60-year-old lady who was, like 110 pounds soaking wet. And we had just put the same size stent in a 6'6" guy, and we're putting the same stent in this little tiny lady. And, it doesn't make for good healing. It doesn't make for longevity of that device because it doesn't fit, right? Now, we're doing much better with that. We've got different sizes, et cetera. But we still can only open up heart arteries that we can see. Some women have very microvascular, very tiny occlusions in their heart arteries, which can cause little tiny bits of damage, sort of, and they're not like the, I'm having the big one, there's one central spot. It's just a general feeling of not being well and having the heart just not being able to meet the demands of the body. Sometimes there's a coronary artery spasm that can happen. That can happen with hormonal changes. It can happen with smoking, etc. It's where the heart artery actually squeezes off, but then relaxes with medication. There's also something very specific, not very specific, but disproportionately represented in women called spontaneous coronary artery dissection, or SCAD. And it is something that it happens a lot in women. The inside of the artery has a tear in it, which causes pain, which causes potential damage to the heart muscle. When we go in to look at that heart artery, it's not related to plaque. It's not related to cholesterol. It's not related to anything. It's just something that happens because of wear and tear and stress. So the good thing is that in the last 5 years, we've gotten really a lot better at managing these specific women disproportionately represented syndromes. We've gotten a lot better at it. We need to get a lot better at it still. So these are just some of the unique syndromes that women are, that we see a lot more women with. One of the things is called stress cardiomyopathy. That sort of harkens back to, remember I said like a pregnancy is a 9-month stress test? Sometimes later on in life, with all of the roles and responsibilities and stress that women have, they develop this stress cardiomyopathy, sorry. And it's a stress on the heart which causes the heart not to be able to meet the demands of the body. Once again, this is also very treatable with rest, but the diagnosis of it takes a little while because it does present in women a lot more than men. The other one that we see a lot, especially in young women, is called paroxysmal orthostatic tachycardia. And so what happens is some women with this, they have a very high heart rate and very low blood pressure. And it causes them to have really a lot of difficulty functioning. It happens in young women after pregnancy and can happen or can continue on until menopause, and then it usually settles out after that. But it is hard to get a diagnosis. I think we covered most of those other ones. So the trouble with women is that way back in the day, this was typical chest pain, and then all of my schooling, this was atypical chest pain. So when you see women that present with symptoms, they were atypical, and that sort of meant that they were wrong, right? Atypical is wrong. So women that presented differently than men, that was different, but it's actually how women present. We didn't know any better. So because of how our hearts are put together, how they're engineered, it's very difficult to pinpoint where your heart, if you're having chest pain or if you're having chest or heart symptoms, it's very difficult to pinpoint, put a finger on what's going on. You don't have a lot of nerves around your heart. If you burned your finger, you would know exactly what side of your finger and how long and how much it hurt because you have so many nerve endings in your finger. In your heart, you don't have that many. And women have different innervation than men. So when women have issues with their heart, it is different than men. And if it's different, and we've all medical people have been taught that this is the way that a heart attack happens, anything different than that needs a lot more evidence, push, etc., to be convincing. Does that make sense? I mean, it doesn't make sense, but it makes sense. So women that present with a vague feeling of discomfort in their chest and indigestion, oh, it's, you've got something wrong with your stomach, here, take this, go home, okay? Oh, I've got shortness of breath, and I've got this funny feeling in my chest, and, I'm nervous. Oh, anxiety, go home. So that's traditionally how women have been sort of delayed treatment in the past sort of 20 years. It's been passed off as something else because, we didn't present with the hand on the chest and, them having the big one kind of a thing. So everybody is different. And like I said, I worked in the cath lab for quite a long time. I worked in cardiology for quite a long time. Every patient that I saw that had a heart attack had a different story about what their pain was like or what their symptoms were like for their heart issue. Chest pain is also another word for angina. It can be in the center of your chest. It can go through the back of your chest. Your heart is a very funny shaped thing. It actually sits almost like this. Oops, sorry, I'm crunching that mic there. It sits like this in your chest. So if it's this heart artery that's the issue, it sits on your diaphragm. It can cause stomach upset, but it's your heart. Okay. So when we ask over and over again in the emergency department, in the ambulance, at your doctor's office, what your symptoms are, it's a good idea to be fairly specific if you can. Sometimes it's hard to be, but these are sort of traditional things that may think, oh yeah, I'm having a cardiac event, because they are sort of what we've been taught. You've seen them on the side of a bus probably growing up, right? But some non-traditional things are vagueness of these symptoms and then lightheadedness, unusual fatigue, indigestion that doesn't go away with treatment, neck, jaw, or shoulder pain, heaviness in one or both arms, shortness of breath, back pain, or upper abdominal pain. So I have a little story here that I just want to read out because this is a good one. So this is a woman who is 60 years old, and she had something called spontaneous coronary artery dissection. So my symptoms started in May. A typical morning for me was gardening nonstop for 2 hours, but after just 20 minutes, I felt completely exhausted. Every day I napped in the afternoon for as many as 2 hours, and yet I was still exhausted. I wondered, with all the stress in my life and being extremely fatigued, was my new normal. Then in July, things changed again. I was watering the garden and felt something wasn't right. I felt a slight chest pain, but dismissed it as indigestion. A couple of hours passed, and I was still feeling off. As I lay quietly, I noticed a pain in my jaw and my right arm near my shoulder. Then I felt the pain start to move down the arm towards my elbow. I had never had this feeling before. After discussing the symptoms with my spouse, we decided to head to the hospital, and a blood test at the hospital confirmed I had suffered a heart attack. In the hospital that evening, I experienced another heart attack and was transferred to the Heart Institute the next morning. The diagnosis was spontaneous coronary artery dissection, resulting in 3 tears to my artery walls. This is a fairly new discovery, and it affects women more than men. In hindsight, we should have called 911 for an ambulance, as they would have started the cardiac assessment right in my home, and they would have fast-tracked my admittance and diagnosis. So that's a story of a woman who went through cardiac rehab a few years ago. And she's actually started a Facebook group on support for SCAD, or as part of a support group for SCAD. So I guess the message is, if you feel different than you normally do, and and it's something that you feel strongly about, go to an urgent care, go to an emergency. If you have any sort of chest discomfort, urgent care or emergency is obliged to give you an ECG, usually within 20 minutes of arrival. And then that tells them something. There's also blood tests that are done 4 to 6 hours apart, which tell if your heart is in distress. Your heart sends off an enzyme that can be detected in the blood, that can be detected fairly early, and we see if the heart is in distress. And then, of course, St. Boniface is the heart cath lab, where we do angiography, and we can see what those vessels look like, and we can see if we can fix them. So advocacy for yourself when you present is really important. Some of the things that I've noticed with how women adjust to having heart issues or heart diagnosis, or even before they've been diagnosed, is women tend to put everybody else in front of them, especially nowadays where we have homes and kids and work life, and we're pulled in very competing ways. So the person last on the list is us, right? Because we're just going to push through it and carry on. But if you're not there to carry on, who's going to look after all the things that you know and love, all the people you know and love? Cardiac rehab. This is very unusual to have a room full of women. I've been running the cardiac rehab program for about 4 years, and disproportionately, I have men in my classes. And you know why I have men in my classes? I asked them. My wife made me come, right? But then I asked the women, and I asked them, so what made you come to cardiac rehab? I'm so glad you're here. And they say, well, if I don't do it, nobody else will. But that's women's mantra for everything in life, is if I don't do it, nobody else will. So those few women that come here and prioritize themselves first end up having better control of their risk factors going forward. And all the guys that come through, all the men that come through, I say, hey, you're lucky you got somebody who loves you enough that they want you around a little bit longer, right? But yeah, even women that come to cardiac rehab, a lot of them don't finish because other priorities sort of derail you. And if you don't finish cardiac rehab, that's fine. But there are pearls that you can take from cardiac rehab, cardiac prehab, which I'm going to talk about in a second, that can make your life longer and better, prevent you from going into the hospital to see those cardiologists who get paid a lot of money. Some of the things that for diagnostic testing and advocacy, it's a good idea to have somebody with you if you're at a medical appointment where you really want to push your issue. I have a lot of friends my age now who are menopausal and having issues with the incredible burden of their symptoms and trying to live a normal life. And they're trying to balance that with advocating for themselves for hormone replacement therapy or not, having a good conversation with their doctor about that, versus the risks of, some of the risks, depending on what your history is, of starting hormone replacement therapy. Once again, there's a lot of sort of misinformation about hormone replacement therapy out there. But advocating for yourself and knowing what your options are is really important, and having a good conversation with your family physician and knowing yourself. So knowing your health history, being able to present it to your doctor, taking a sheet of paper, making sure that your questions are answered before you leave a physician's office is also quite important. I'll talk about support in a little bit, and CPR I'm not going to deal with today because we're getting sort of close to, I want to talk about a couple other things. I had a friend from Calgary send me a message, what was it, Thursday, when I put that thing on Instagram about this topic starting this week. She goes, oh, I just came from my doctor's office, and they told me I was pre-diabetic. My A1C is 7. So they're going to come, I have to go see her in July or something like that. And she has a cottage next to us, and I have to do something, but I don't know what, right? And she just turned 60. She is the best baker in the world. Oh my God. And she said, okay, so I cut out white bread. Like, that's amazing. And it's been a week, and she says, I haven't had white bread in a week, and I haven't baked in a week. I don't know what I'm gonna do with myself. I'm crazy. So she has all of this energy, but she doesn't know what to do with it. And so one of the things that we talked about is sort of where you're at, right? So you've rid your house of all sugar. So or white bread. We went through white bread, we went through muffins, we went through all of the stuff over the phone. So she was prepping, right? But she's not quite ready. Her husband is not ready for this either, I'll tell you that. And she's sort of in this phase where she's trying to figure out, okay, what do I do? What's going to give me the best bang for my buck? Is getting rid of the white bread the best bang for my buck? When she's been diagnosed with prediabetes, she says she's 45 pounds overweight. Her blood pressure is high. So she's been given this massive problem, right? All these things are wrong with you. See you in 3 months. Okay. So, like I said, she called me and I said, okay, you know what? You did great. That's great. Get rid of your white bread. Now, all I want you to do is I want you to walk 20 minutes a day. Not 10,000 steps. I want you to walk 20 minutes a day with purpose. Go outside, get a little short of breath, get some fresh air. Don't walk the dog. This is for you, 20 minutes a day. So she sent me a text last night. She goes, yeah, I did 4 out of 5 days. Like, awesome. When you do 7 days, 7 days in a row, then we're going to add 10 minutes. She's like, oh my God, my bum is so sore. I'm like, that's great. That means things are waking up and you're moving. A lot of the things that the doctor told her to fix are fixable by moving and not just 10,000 steps. If you think about when you were in your 40s or in your 30s and you had little kids or you had nieces and nephews, you were up and down off the floor, you were up and down the stairs, you were more active than you potentially are now. You're more flexible, of course, than you are now. So doing those little things is important to start. So her next step is maintenance. So keeping the 20 minutes a day, but then adding something. We're going to add doing weights a couple of times a week. Or we're going to add something spicy, like she's going to go for a bike ride a couple times a week, right? Just to sort of figure out. And then in a couple weeks, she's going to, go on a trip to Mexico or something and not walk at all. And that's okay. Forgive yourself and then get right back on the horse and get going. It takes so long to develop a good habit. Like, really, it takes so long to develop a good habit that it's important to, if you do get off your habit, to get right back on. Okay? So this is the Canadian Health Guide for activity. So 20 minutes 2 times a week. So this is a starting level of moderate and vigorous activity to 30 minutes 3 times a week, up to 150 minutes a week. So you have to know yourself, what you're capable of and how much time you have. I know my friend in Calgary, just as an example, she has 20 minutes a day. And that's really 20 minutes out of 24 hours. That's not bad, right? I know it's hard to kind of fit that in. But once you squeeze that 20 minutes in every day, then it can get easier to do 30 minutes 3 times a week or 60 minutes 3 times a week. But you have to start somewhere, carving out that little bit of time for yourself. This is, like I said, from the Canadian fitness website, what we're expected, what every Canadian is expected or should do. So there are a whole bunch of things that can be changed. Your genetics, your sex at birth, some of your ethnicity pieces cannot be changed, but you can change your nutrition, your weight, your level of physical activity. All of that stuff is in your control, or can be in your control. Okay. So here's some heart health resources. I do have a couple of examples up here. But what I did want to talk about specifically here in Winnipeg is there are two, one is a study, one is health promotion. And the first one is called Her Heart, Her Way. It's actually run out of the Refit Center. It's a combination, it's a partnership between the Refit Center, WRHA, and the Victoria Hospital Foundation. And it is, it's a longitudinal mentorship program for women who don't have cardiovascular disease, but want to reduce their risk. And it has a little scanny thing on the back if you guys want. So you have to be older than 30 years of age, no previous cardiovascular disease, not taking medications. And what this program does is it does some blood work before and after and teaches you about modifying your risk factors. It's fabulous, actually. So this is also information for your sisters, your daughters, your friends. Okay, it's really good information with this program. The second program is a cardiovascular study. It's called the WARM study through the University of Manitoba. And they're enrolling people. I have a couple handouts here. And it is also a combination of a couple of 90-minute appointments at the Fort Garry campus where they do exercise testing and blood work on women. They collect a stool sample as well. I'm not sure what they do with that. But then they follow you for up to a year to see what your cardiovascular risk is. And those are both, this is a women's health study, so this is a very good one as well. The Heart and Stroke Foundation of Canada, the Manitoba chapter, it's all the same website. They have fantastic resources. They have stress reduction resources, learn how to do CPR in 5 minutes, how women's heart disease affects, some resources on women's heart disease that are a lot deeper than what I'm talking about today. So I would invite you to look at those as well. But the bottom line is, it's from a nurse who's been a nurse for a long time, is you have to care about your health, more about your health than your healthcare team. Okay, it's your health. Because when a doctor sits down or a nurse practitioner sits down, they have 30 patients in a day. And they care about your health, but you have to care about your health more than they do. Okay? And I hope I've given you some tools for that. If you have any questions, I would love to chat about anything you want to chat about. I'm hoping that our next fiscal year, we're going to develop something like this. We just have to get some funding. We are looking at developing a diabetes, sort of a pre-diabetes, diabetes program to start off with for sure. But a Her Heart program is something that is on my dream list for early, like summer or fall. Yeah.
You ever heard of someone, a few weeks ago, it felt like I had my phone here, it was like vibrating, like it was, I didn't, but it felt like over here, it was like, but it felt like vibration. What is that?
So the question is, someone felt a bit of a vibration in their chest a couple of times a couple weeks ago. Sometimes that can be a skip beat, a skip heartbeat. That sort of sounds like what that might be. Or it could, it could be that there's, something, you have a lot of stuff in your chest. So you got, your lungs and a bunch of blood vessels and things like that. We probably have to sit down and see what other symptoms you had, if you had any other symptoms. If you didn't really have any other, like you didn't have any dizziness, you didn't have any pain in your chest, it might just be that you had a couple extra heartbeats, and that's just that extra feeling, a palpitation that you might be feeling. I don't know. It's hard to tell. And the thing with ECGs, which we would use to sort of see what that was, is that they only work what's happening right now. They can only see what's happening right now. But if you have more of those, like if it happens more frequently, or if it happens after certain things, like drinking a bit of extra coffee, drinking red wine, or after exercise, or when you're stressed, then that's something you keep a little journal of sort of when it happens and how long it lasts, and if you have any other symptoms. That is part of having a story to tell to your physician about things that you're concerned about. Does that make sense? Yeah. Yeah. All right. Thank you, ladies. Appreciate you coming.